right, everyone, welcome to our next session in our geriatric bootcamp. Today, we're going to be talking about managing acute and chronic geriatric medical conditions, specifically polypharmacy and deprescribing. Today, we have our senior pharmacist, Rob Aceta, who is here with us to talk about today's topic. But before we get into that, we do have a couple of housekeeping items we'd like to get through first. If you're not familiar with the iPro QIN-QIO, iPro holds the federally funded Medicare QIO contract for the regions shown here. Specifically, iPro helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are three organizations working under the iPro QIN-QIO banner. So if anyone asks if you're working with iPro or health-centric advisors or Clarent, you say yes. At this point, I'd like to pass it to Mary Ellen to give us an update with COVID-19. Mary Ellen?
Thanks, Josh. Hi, everybody. Happy Halloween. As of the 21st of October, there was a slight decrease. It's remained kind of stagnant right now with hospital admissions for COVID-19, a slight decrease of 0.2%. However, deaths do continue to increase. As of the latest reporting week, a 12.5% increase in COVID deaths. The latest variance is HV.1 is the new kid on the block. It's the variant that's causing the most disease at 25.2% of cases, followed by EG.5, which we have been seeing. HV.1 is very transmissible. However, it is part of the Omicron family. So again, still good coverage from the vaccine that we have available. Next slide. So I just want to touch briefly on something I mentioned last week, targeting a group called passive positives. So when we look at COVID-19 vaccine updates, it's kind of dismal right now. 3% of all folks that are eligible for a COVID vaccine have actually received one, with only 7% in long-term care residents having received their updated COVID vaccine. So this research article, and I will post it in chat, really talks about targeting a group called passive positives that are a group that have gotten COVID vaccines in the past, but they do approve of the vaccination in general. But they're not very likely to expend energy to get a vaccine. They know it's good for them. They know it provides protection, but the side effects weren't so great, so they're a little ambivalent. And they're actively trying not to think about viruses this fall, aren't we all? But this is one of their characteristics, and it's a large group. So it's 35 to 40% of vaccine eligible population. So just something to consider when I know people are struggling with vaccine fatigue and having that conversation. It uses a communication strategy known as the IIFF model, which again, the article goes into, and this is a strategy used in organ donation for those who are kind of on the fence about being an organ donor, and this is how they have targeted folks to get people to be organ donators. So just something to think about with your strategies as we're in the season pretty heavily right now. And that's it. Thanks, Josh.
Thanks so much, Mary Ellen. So through this course, we're going to just go over the average number of nursing home resident who's most likely prescribed with at least 6 to 8 medications. We know that these medications are crucial to the health and maintenance and recovery of the residents, but polypharmacy really can cause a lot of those concerns. So during this session, we're going to discuss the prominence of those issues with polypharmacy within the nursing home, as well as talk about approaches to deprescribing. So at this point, I'd like to pass it over to you, Rob.
All right, thanks, Josh. Thanks, and hello, everyone. Today's learning objectives, we will try to understand the concepts of polypharmacy and the prescribing cascade and deprescribing, all three. We want to identify some key medication groups and categories that you should consider for prioritizing when you're putting together a deprescribing protocol. And then finally, review some steps of how to incorporate deprescribing into the monthly medication review process. Next slide, please. So here we want to talk a little bit about the concepts of polypharmacy and geriatric syndromes and why these are concerned. And you can see I've given you a snapshot of an article, medications associated with geriatric syndromes and prevalence in older hospitalized adults being discharged from hospitals essentially to skilled nursing facilities. Next slide, please. So the study design in this particular study, a list was gathered. 513 medications were included on that list as potentially contributing to 6 significant geriatric syndromes. And these syndromes should look very familiar to us in the facilities: cognitive impairment, delirium, falls, reduced appetite or weight loss, urinary incontinence, and depression. Next slide, please. So commonly prescribed medications and data, and let's talk about the findings. Out of those that we just talked about, there were 18 different categories of medications that were included and analyzed. And out of them, anti-epileptic medications were associated with all 6 of the syndromes we mentioned. And there were 5 others: antipsychotics, antidepressants, anti-Parkinson drugs, and opioid agonists. And these were associated with 5 of the 6 syndromes. But I think the key here is on the right-hand side of the slide. For folks in the prevalence sample, folks being discharged to your skilled nursing facility, overall, they had an average of 14 medications, plus or minus 4.7%, with an average of 5.9 plus or minus 2.2% medications that could potentially contribute to a geriatric syndrome that we've listed. Falls having had the most associated medications at discharge at 5.5%. So again, just thinking about all of the risks, how we can mitigate those risks. Next slide. Now we'll talk a moment about the prescribing cascade. And there's a significant discussion about prescribing cascade and what does that mean? So it begins when a drug is prescribed, an adverse drug event occurs that could be misinterpreted as a new medical condition. And then subsequently medication is prescribed to treat this drug-induced adverse event. The identification and interruption of the prescribing cascade is really important in our facilities because this is where we find adding on medications causes and leads to unintended consequences. Next slide, please. And this is just a general observation. And my comment is, has this ever occurred at your facility? And you can certainly say, yes, it has. You have an initial medication prescribed. It could be misinterpreted as a new medical condition, and then subsequently another medication is prescribed, could include a prescription or over-the-counter drug, or even adding a medical device. Next slide. Okay, and another article, this actually comes from our CDC reference. It's called Polypharmacy and Health-Related Quality of Life Psychological Distress Among Patients with Chronic Disease. So this is really in the sweet spot of what we want to get to today. Next slide, please. So here we kind of need to recognize that chronically ill patients and residents tend to have really a high risk of multimorbidity, and therefore the reason for using many medications, multiple medications, is common. Polypharmacy, which in this article, it's defined as the use of 5 or more medications, will naturally increase the risk of adverse drug or drug events, adverse drug disease interactions, which can negatively impair and affect a patient or resident's health-related quality of life. Next slide, please. So the takeaway from this study and article is that there were no significant associations found regarding the mental component of the health-related quality of life, suggesting that there's an unfavorable effect of polypharmacy only on the physical domain. So again, think about all the different areas that we must ensure safety for residents. And that is why we're talking about this particular study. The results supported the need for healthcare professionals to recognize drug-related adverse events and also to recognize the negative effects of polypharmacy, especially with folks with multi-comorbidities, which we see in our facilities all the time. Next slide, please. Go to the next slide. Oh, okay, thanks. So some concerns related to polypharmacy in facilities and nursing homes. Number one, the medication regimen is very complex. Timing, combinations of medications lead to problems. Doses, side effects, interactions therapeutic duplications, adverse drug events, all possible, probable with these multi-combinations of drugs. The time needed to administer during the medication pass for residents safely. Specialists for every organ system. So we might have specialists who prescribe who may not communicate or review the entire picture of the medication regimen for the resident. Finally, pharmacy provider concerns. There might be concerns providing the medications due to some barriers such as insurance or prior authorizations. Next slide, please. Now we'll talk a moment about deprescribing. So here's a definition from the US Deprescribing Research Network. And deprescribing refers to a thoughtful and systematic process of identifying problematic medications and either reducing the dose or stopping these medications. And it really must take into account methods that include safety and effectiveness, which means going back to look to see that your intended outcome occurred, and just to help folks maximize their wellness and goals of care. Next slide, please. So some actions and benefits from deprescribing. The provider would perform a benefit versus risk assessment of medications, and therefore the goal would be to reduce unnecessary medications. This is going to be a theme in future slides we talk about. Reducing the risk for side effects, adverse effects, and improving the quality of life. When deprescribing, of course, the reduction of risks may or may not reduce the overall mortality associated with the multiple medication use. And finally, deprescribing isn't just stopping or discontinuing a med, but it really does involve a thorough review of the entire regimen and a follow-up. Next slide, please. So I have a learning question for us, and you can type your answer into the chat. We'll give you a pause here. Which of the following is false? Deprescribing, A, involves a systematic review of medications. B, involves stopping one medication at a time if possible. C, is required according to CDC guidelines for safe medication use. Or D, is one approach to combat the risks of polypharmacy. So feel free to type your answer in chat. All right, we have folks that are engaged. Let's go to the next slide and get your answer, the correct answer. You've got it. See, it's not a requirement according to any CDC guidelines for safe medication use, but all of those other points are very important and true. Next slide, please. So how to start? Let's talk about selecting medication categories to get started with this deprescribing process. So you want to identify key medication groups and categories to really take a focus or pick one when putting this protocol into action. And I think there's a couple of things that you should consider. First of all, this low-hanging fruit, we look at some categories that are not that difficult to review. And we also must have our providers and consultants reviewing with the risk-benefit analysis. And then finally, if you look like Bart Simpson, don't worry, we can help you. We have some ideas and suggestions for you. All right, so deprescribing medications by drug classification. We have a reference here for the Canadian Medication Appropriateness and Deprescribing Network. And so this is a internationally known center really for helping to get folks on board with deprescribing. This organization has been active for many, many years, and they've created some evidence-based guidelines for the following categories. So for your consideration, if you wanted to tackle any one of these first five, you would potentially use their resource, and you could try the proton pump inhibitors or the anti-hyperglycemics, which we know are associated with adverse drug events, antipsychotics, another group, adverse drug events, benzodiazepines, the Z drugs, drugs for sleep, high risk, adverse drug events, and then cholinesterase inhibitors. So there's all evidence-based guidance that they provide on their site. Next slide. Here's an example if we focused on the proton pump inhibitors, and what I've done is just given you a snapshot of what that site looks like. And again, you can really take a look at these on your own time and click on any of the links in the slides when you receive them, and you go right to that particular resource. Next slide, please. Now, here's some ways to look at medication categories with increased risks for adverse drug events. So not only the typical category that we just looked at with regard to deprescribing, but looking at high risk for adverse drug events. And here I want to read them out because I think it's important just to hear it. The analgesics, we know, which includes opioids. Antibiotics are high risk. Anticonvulsants, we mentioned that on the earlier part of the talk. Antidepressants, antihistamines, which cause, again, high risk for sedation and bad outcomes. Antihypertensives, antipsychotics, and anxiolytics, which you mentioned, the benzos. Central nervous system acting agents, so muscle relaxants. Hypnotics, muscle skeletal agents, and urinary drugs. All of those are opportunities to assess. Next slide, please. Medications with a high anticholinergic burden would also be medication categories to look at. So high levels of anticholinergic burden have been linked to an increased risk and severity of drug-related adverse events. And here they are. Lower physical functioning, that's a problem for us in facilities. Higher risk of falls, higher risk of cognitive decline, especially with multiple medications. When we add multiple drugs that have a small anticholinergic burden, we get the additive effect. And then finally, higher all-cause mortality. Next slide, please. Here we want to just talk for a moment about, again, the drug regimen review. We also call this the medication regimen review. I think, again, in facilities, you're looking at section N in the MDS, where you're talking about the drug regimen review. Here you want to review the pros and cons of incorporating deprescribing into the medication regimen review process. And that usually happens primarily by the consultant pharmacist. And I've given you a snapshot here of the FTAG that's, related to the drug regimen review at 756. So again, just for what the requirement says and what the pharmacist must do, this is what the pharmacist is responsible for. But I think, in conjunction with this talk today, we need to remember, anytime we're doing deprescribing, reviewing medications and eliminating them, we also must really document very clearly in the chart. So the consultant pharmacist would document in the medical record the recommendations they make. And if you yourself are doing the deprescribing in your facility around the consultant and you're looking at categories, you also must include a progress note to show what the intention was, and then a follow-up note to show how the outcome played out. Next slide, please. So deprescribing and the medication review, here's some thoughts. When should a review occur? And here's a couple of opportunities amongst many. At every care transition, including going from home to the hospital or from hospital to the facility and then facility to home. At the facility during the medication regimen review by the pharmacist with help from a nurse staff if possible or if appropriate. Even at a brown bag event in assisted living facilities, something that could be performed. Usually it's done with patients and families by the pharmacist, and then at a prescriber's office or in a clinic performed by the patient or the family member and a nurse or a practitioner. Next slide, please. So creating a deprescribing initiative. Here's some thoughts about how to do that. First, you want to collaborate with your stakeholders in your facility. And those are key leadership folks, the director of nursing, medical director, consultant pharmacist, and the resident, of course, and the family caregivers. You could request reports from the pharmacy vendor, or you can download these from your electronic health record if you're able to do so. Create a goal, give some dates with timelines to accomplish the steps. And then they could also be performed during either the 30-day or 60-day medication orders renewal, and really recognizing the clinical inertia that we all can be overcome with when it comes to medications, which just get routinely continued and reordered on that cycle. Next slide, please. So prior to incorporating this deprescribing process, you've thought it out, and now you have the key stakeholders on board. You also need to consider evaluating some of these factors. Education, so it needs to be by the facility medical director, director of nursing, consultant pharmacist, not just amongst themselves, but to all the staff that would be involved. And that includes all the other disciplines that take care of the residents. So think about who else. It's the therapist, it's your recreational folks, it could be your nutritional folks. All of the folks in your building should be educated about this plan. Include the medical providers, so any attending physician or other providers such as nurse practitioners, physician's assistants. And then finally, you can consider incorporating a discussion at resident council to discuss polypharmacy, or deprescribing for residents and patients. And you'd be surprised how response generally is very good when folks hear about this initiative. Next slide. So some benefits that accrue from deprescribing: patients, residents in the healthcare system, fewer medications. Is again, what we've talked about, reducing the adverse drug events. And then in the facilities, by potentially having fewer discharges because sending them out to hospitals due to drug effects, drug events, adverse events. And then also as a methodical review of medications will help meet the requirement to eliminate unnecessary medication. So think about just compliance in general. You can see at the bottom here on the left-hand side, we have a snapshot of the 757 F tag, which discusses unnecessary drugs in the general requirement. And it just goes back to what we're talking about. If it's not necessary, they shouldn't be receiving it. Next slide, please. Okay, learning question number 2. Which of the following is false? The medication review process, A, provides opportunity to reduce unnecessary medications. B, gives patients and their families quality time with a professional to focus on their medication regimen. C, takes into account duplications and med pass schedule in a facility. Or D, is similar to the medication regimen review performed by the pharmacist monthly in a skilled nursing facility. I'll give you a moment, put your answer in chat. What you think about this one? Okay, let's go to the next slide. We'll give you the correct answer. The correct answer, all A, B, and D are all true. C, in this case, it doesn't necessarily take into account duplications and or the med pass schedule. It should take into account duplications, perhaps, but not necessarily the med pass schedule. Okay, great. Next slide. This is really just a reminder, don't practice in a silo. So no matter what your discipline is, we all have to practice together for the benefit of the resident. They do have multiple medical comorbidities. And so the generalist or the specialist could order medications to treat one particular condition without, again, recognizing the other comorbidities they have. And that could be a failure, which would lead to adverse outcomes. So just, again, common comorbidities: heart failure, diabetes, hypertension, behavioral health concerns, chronic pain, or substance use disorder. All of these may require medications, and this is where we have that buildup of that cascade and polypharmacy. Next slide, please. So we should also recognize risk factors that incorporate part of this process, and that would be the social determinants of health. You see them listed here: the age and sex of the resident, the race, social economic factors, the home environment, and home includes whatever type of residential setting. If it's a nursing home, could be any other facility, assisted living. Health literacy is important as well. And then finally, ability to self-advocate that the resident may or may not have. Next slide. The prescribing efforts, pros and cons. So pros, the efforts can help in risk mitigation. That's a huge concern. Nursing time and cost savings, and a better quality of life for folks that live in the facility. And the cons, when the efforts are not a team approach, and when they're occurring without the best interest of the resident at the forefront, they should really always include a follow-up assessment to determine the response to the attempt to deprescribe and what the outcomes were. Next slide. There's some barriers to deprescribing: resistance from family members or residents, fear of losing the patient provider relationship, the concern from clinicians to discontinue medication started by another provider. Oh, and I want to touch that medication, I didn't order it. The time that's involved to do so, the fear of drug withdrawal side effects, and then finally, lack of resources. You may not have a clinical pharmacist available or the access to the database to review the information. Next slide. Here's an example of something that we were trying to do during the early parts of the pandemic and during the early parts of the COVID crisis. So one organization, University of Maryland School of Pharmacy, collaborated with stakeholders, and they created an optimizing medication management during the pandemic. So this is where they looked at all the different categories of medications to decide what to recommend that could be held or deprescribed during the crisis. Again, thinking about providing medications to folks and the staffing concerns and just having enough folks to provide care for residents. How could they have an impact? This was really helpful during that time. And so it's just here as a reminder. You can even look at this resource to see what might be helpful for you for deprescribing. Next slide. So this kind of sums up our polypharmacy and prescribing cascade and deprescribing talk today. Next slide. If you have any questions and contacts, you can contact the iPro Nursing Home team. There's our email, and you also can contact me directly. Be happy to help and assist with any concerns. And the next slide, I think, will just remind us about how we can all stay connected on social media. And with that, I'll pause, take any questions or any comments, turn it back.
Thanks so much, Rob. Does anyone have any questions for Rob in regards to today's session or anything else?
Rob, it's Lynn. So I think as a provider, I think you sort of briefly touched upon the idea of deprescribing on medications that the provider didn't initiate. And I think that's a huge barrier for nursing home providers, whether they're APPs or physicians, to initiate the deprescribing process. So any other thoughts regarding that psychologically or otherwise? Because I think that's a bigger issue than we give it credit to, and I think that might end up being the reason why many people stay on bad drugs longer than they need to.
Yeah, hi, Dr. McNichol. Thanks for commenting on that. I think, one suggestion that I would offer is, having done this for a while, it's really to get the staff on board, and it starts at the top with the perhaps even the administrator, the medical director, and the medical staff getting in a room together and having the consultant pharmacist in the facility as a resource at that meeting and just explaining the process. And it's about looking at communication. It's really folks understanding what's at stake and what the goals are. And then, even you as a medical director or the medical provider may interact with consultants who are recommending medications. And that's where the medical director steps in and has an outreach with, let's say, for instance, a consultant psychiatrist who's recommending antipsychotics, or the consultant pharmacist can do that. I've done that. So we do need to do a better job of communicating and having everybody on board. And I think that really does go a long way to help in the process where folks are just concerned about not touching somebody else's prescribed medications. I hope that's helpful.
Yeah, thanks. That's great. I'd also, in this day and age, we're connected in many ways electronically. So when I know that the provider, like a cardiologist or a pulmonologist or something, is ordering a Beers list medications, I might reach out to them through the electronic medical record for the health system. And sometimes I try to word it in such a way that they won't have any choice but to agree with me. It's like my lawyer language. Given that this person has fallen 5 times in 2 weeks and this medication causes falls, I wonder if there's an alternative. I was thinking of this medication, which doesn't cause as many falls. What do you think? And then it becomes a no-brainer. They have to agree with me, otherwise they're agreeing that this person should be falling.
Good tactic. Yeah.
So I'm not seeing any other questions in chat at the moment. So we can move on. I just want to highlight that we have our upcoming education summit for our nursing homes. We have New Day that's going to be taking place on November 30th from 9 a.m. to 3 p.m. We have a lot of great topics, hospital and nursing home collaboration, QAPI, NHSN and MDS updates, addressing staffing challenges. So a lot of great topics. Please come to the session. It's going to be a great opportunity. They're going to be back-to-back sessions. It's going to be going all day. So if you can stay for, if you can just pick one of them, come to that. Or if you want to stay for the entire day, that's fine as well. But you have the freedom to come and go as you please. So registration is with that QR code as well. I'll be sending out the slides to everyone who attended today's session. So you'll have the link with that as well. And then with that, if you have any other questions, feel free to contact the nursing home team with the iPro QIN-QIO for any of your quality improvement needs. And with that, that'll be it for today's session. Thank you so much, everyone. Hope you have a great day.